How you guys doing today? It's Anthony Gangi and welcome to another episode of Tier Talk. And today is going to be a very unique episode. This episode hits home for those that work in jails and in prison because we're going to talk about involuntary psychiatric commitment. And as you can tell in our prison and jail population, they're coming. With the closing of a lot of state hospitals, our numbers have increased with patients or inmates who have special mental health concerns. So today my guest is going to be Dr. Annette Hanson. She's the author of a book called Commitment, which focuses on involuntary psychiatric commitment. So first, I'd like to thank you, Ann, for coming on the show. Thank you.
Thank you for having me.
Pleasure. First off, I did get a chance to read your book. Your book is excellent because your book actually is a group of different stories and how each person relates to the treatment that they're given, and each person also has a different diagnosis. But the key to the book is each person that's being treated was treated, some chose to get treated and then some were forced into it. And that's kind of what I want to talk about today because our prison setting does that. Our prison setting kind of handles both. They have inmates that know they have issues who will voluntarily go in for treatment. And then for safety and security concerns, we have inmates who don't know or don't think they may need it. And then we're forced to involuntarily put them into our psychiatric treatment program. So right off the bat, do you feel there was a need for the book that you wrote?
Absolutely. One of the reasons why we wrote this book, my co-author, Dr. Dinah Miller, and I, along with another colleague, Dr. Steve Davis, started a blog called Shrink Wrap about 10 years ago. And in this blog, a number of people wrote in who were former psychiatric patients. And these people had been civilly committed, held against their will, and sometimes treated involuntarily with psychiatric medication. And the stories they told were quite vivid, and some of the people recorded upsetting and traumatic memories of these experiences long as 10 years later. And so we thought it would be really important for the people in charge of passing legislation and writing healthcare policies to hear these stories.
Now, are we more concerned now than ever before about how the patient feels when they're going through treatment?
Well, that's kind of the point of the book. I don't think we're concerned enough about how patients feel about this. In recent years, there have been a number of very high-profile tragic events like mass shootings, and that has led the federal government to work on legislation to loosen involuntary treatment criteria, to modify gun laws specifically targeting people with mental illnesses. And we were concerned that somewhere in there that the voice of the patient was getting lost. So that's one focus of our book.
Right, and the big part of that, now when we talk about the correctional setting and the jail setting, there are times where, we have to put that person in. That person needs to be treated immediately, and sometimes it goes against the person's will, and in some cases, some would say it goes against their civil rights. Do you believe at some point safety and security has to trump the individual's want to be in treatment?
Oh, absolutely. And the irony here is that in the correctional setting right now, it's almost easier to get treatment than it is out in the community. There are some places of the United States where there's only one mental health professional for 1,000 people. And our own local city jail, before it closed down, had more per capita mental health professionals than the small town where I grew up in the upper Midwest. But going back to your issue of security, yes, I think the safety of the individual and the safety of the people around them have to be taken into consideration when you design a treatment plan. That's true in corrections, and it's true in the community as well.
And do you see an increase of inmates with special mental health concerns coming into the correctional facilities?
I'm going to add a caveat to that because here in Maryland, there's been an initiative that's fairly progressive, and that's been going on for a while now. Our community has a mental health court. They've expanded the number of mental health courts in the state. We have community treatment programs where treatment providers will go out to wherever the patient happens to be to offer them care. And so we've traditionally had a pretty good progressive stance towards offenders with mental illnesses. Now, that being said, there's always more that can be done. So in my own local region, I think our numbers have been fairly stable because we've been really aggressive about addressing it. but that's not the case in every part of the country.
Right, because there have been concerns nationally of the increase in numbers because state hospitals have been closing down, correct?
That's correct, and that's another interesting twist here in my own state. Our city jail, which was one of the larger jails in the country, was closed down 2 years ago. And now we have pending litigation in our state hospital system filed by public defenders for the people who are waiting in the few pretrial beds to get sent to hospitals.
Now, the inmates that come in with mental health concerns, what type of risk do they now present to staff?
Well, I think that the risk to staff is a minority risk. Okay, it does exist, but it's not nearly as high as the risk of the patient to himself. So the correctional clinic typically is a high-risk suicide clinic, and a lot of our efforts are targeted at screening and identifying and intervening to prevent suicide. That being said, there is absolutely a risk of violence to peers and to staff. That's usually not due to a mental illness, however. That's usually due to personality disorders. It's usually due to interactions between staff. It's usually due to learned maladaptive behaviors. And a very small occasional, it's due to a mental illness like schizophrenia or bipolar disorder.
Now, you know what's great now is that now that we're being aware of it, the system is being aware, you could start seeing that a lot of jails, because it's the jails that have a lot of traffic of people coming in and off the streets, and sometimes with the jails, at least a few years back, these individuals may come through the system, not really go through any type of evaluation, and they get released and not realize that they have any problems to begin with. But now you could start seeing a lot of jails stepping up their efforts to try to diagnose the individuals that are coming in. So you on the mental health side, you know, and getting the mental health perspective, how important is it for the people that are coming into the facilities, getting arrested, coming back and forth, to be evaluated, mentally once they enter the jail?
I think it's crucial. And that's the good news piece of this puzzle, because the U.S. Supreme Court said a few decades ago that correctional facilities have to have intake screening, they actually have to have treatment, they have to have trained mental health professionals. And so the quality of the care is getting better. It's certainly not perfect. I'm not going to be an apologist for the system. But during this time, what the national statistics have shown is that putting these systems in place, putting these services in place, has substantially reduced the rates of suicides within correctional systems. Right. So having treatment available, especially voluntary treatment, can save lives.
And you noticed, I mean, I thought that was a great idea to kind of get at the jails, because believe it or not, the prison settings, we know we're going to deal with the inmates a little bit longer, so what we do is we have a lot of stuff in play, like programs. We have some activities, but we devote a lot of our time to programming, education, because we know when we get the inmate, they usually have more than a year to do, so we focus on the long term. But I do think that when we implement these things at the jail setting, it's good because it starts the foundation,
right.
And again, I think it's a great effort, because that can also help the inmate if they do got to wind up doing prison time.
Yeah, no, I think that's really a good point. And I want to emphasize what you said about the importance of programming. So as a psychiatrist, my role is primarily limited to intake diagnosis, some crisis intervention services, and medication management. But I'm only one piece to the puzzle, and you have to have a multidisciplinary team to manage some of these patients. So when you talk about programming, you're talking about licensed clinical social workers, psychiatric nurses, teachers to provide education, as well as the security staff. You really have to approach this as a system and as a team.
And you know what's funny is, I know in the streets they talk about community policing and it's utilizing all resources. I believe corrections has been doing that for a long time. Like we always have an immediate network. If an officer has an inmate that has a problem, they can easily contact whoever they need to get to help address the inmate's needs. And it's great because it's an instant access. And I see now the streets are kind of doing that now with community policing and giving the police the resources that they need to deal with the inmates, to deal with the civilians that may have those special needs concerns. So it's good to get those resources out there and let the people in need, like custody staff or police officers on the street, to know that these resources are there. And then also sometimes the civilians may not know they even need it, let alone know it's even there.
Sure.
You know, and your book emphasizes that. Your book has so many different perspectives, because when I read your book, you know, I read most of the individual stories that you had, and you had stories that they're quite balanced. You had stories where people appreciated the help that they needed because they realized that there was something wrong, and then you had those that were kind of fighting against it because they didn't realize anything was wrong. And when it comes to that, is there a difference in approach?
Well, I think there is a common approach, at least from the standpoint of the treatment provider, and ideally you never want to have to resort to this. This is a last-ditch option. The problem is, in the community, there's so much pressure for fast turnaround time, limited number of outpatient visits, limited number of inpatient days. The community treatment providers just don't have the time now to establish the kind of therapeutic relationship that's crucial for working with serious mental illness. That's where corrections really has the advantage. In prisons, at least in our state, the average felon is sentenced to 5 years and serves about 2.5 years. And we have all of that time. So we don't have to force someone to take medications immediately if they're not dangerous or if they're merely symptomatic. We can take the time to study them, watch them, clarify a diagnosis, gather outside information, and make sure we know what we're dealing with before we set up a treatment plan. That's a luxury that doesn't exist anymore in the community.
Well, let me ask a question. When we have someone on a treatment plan, and let's say they get towards their release date, how do we continue the service?
That's the challenge. This is the latest breaking issue in correctional litigation. So how do you ensure continuity of care between systems? And honestly, I don't have a good answer for that yet because community resources are pretty lacking. Now, one thing that's starting to happen in some states is that there are organizations filing suits against the state for maintaining people in institutions just because there are no community services. These are called Olmstead suits based on the U.S. Supreme Court that created the basis for the lawsuit. And so some nonprofit organizations are trying to use these suits to boost community services, build up clinics again, create supervised housing settings so that some of our either offenders or committed patients can be safely transitioned back into the community without starting that cycle all over again.
Well,
I think this is going to be a good thing in the long term.
Well, when you're talking about safely transition, that's key, obviously. We want to make sure we do what we can for the individuals in need, but that leads me to another question, because when we're talking about safely transition, what about if we have an inmate that's getting closer to their max state, but we still feel they're under that forced med protocol, that they're still in those that TCU type programs? I mean, what do we do? Because now they're getting ready to get released, and let's say, I know we can forward them to be civilly committed, but let's say that that forward gets denied. What's the next step? How do we ensure that that person is going to continue treatment?
Right. Well, systems are going to handle this differently. So in our state, we have by policy, when someone is within a certain time of a release date, they're required to be referred to our social work program to have community services set up and to get, have their housing plan set up, to get hooked up with medical appointments. Now, personally, when I work in my clinic, I always ask the patient if they have open court dates, if they know their maximum expiration date, if they know their mandatory release date. And from the first time that I start working with them, I'm thinking, when do we have to start hooking this person up? So our state has a statute that requires our system to provide a 30-day supply of medications upon release to any offender getting out on parole. Now, that doesn't sound like, that's it. You're just going to give them 30 days of meds. That doesn't sound like much, but that's more than we had 10 years ago. I was informally giving telephone orders for my patients who got released, but that was not part of our policy back in the day. So these are the things we're working on now.
You know, I always tell people there's always that push from when people are on the inside to do better, but then when they get on the outside, where can they go? And that's the key too. We can't just focus on their time on the inside and expect us to be able to produce miracles. The work is ongoing, and when the work gets lost on the outside, some people always look at the system and try to blame the system. It's like, if you actually looked at the system is highly evolved, aggressive with the needs that need to be met, and then when the inmate travels out and let's say they make a bad turn, it's not the system. The system stepped up. It's what are we doing afterwards?
Right. Well, Some programs, I think this is good. Some states have mental health parole and probation, which I think is a terrific idea. So these are specifically trained parole and probation officers who carry a smaller than the average caseload, specifically for offenders with serious mental health needs.
Now, let me ask, being that now you see these inmates with mental health concerns coming into the correctional facilities, coming into the jails, what type of training would you like to see staff go through?
Oh, goodness. There are staff members who, in my experience, have not needed any special training to work with seriously mentally ill prisoners because it comes to them naturally. So I like to see correctional officers, as you probably acknowledge too, who have very even temperament, thick skin. They don't take things personally. They're very patient. They're good listeners. And those are really the skills. As much as that can be taught, that should be incorporated into all officer training. It comes in handy when you're working with the seriously mentally ill, but also with prisoners who have serious personality disorders who can be much more disruptive.
And speaking of that, what's funny is, I obviously still work in the system, and sometimes you have inmates that, they constantly hear people talking about them, and sometimes they think it's staff, and it may not be staff. It may be something that's inside their head. How do you try to convince them what reality is?
Mm-hmm. Well, again, for some things, for instance, with working with delusions, you cannot convince a person who's delusional that their delusion isn't true. That just doesn't go away with kind of talk therapy or counseling. That really does require medication. And so in cases like that, you don't try to convince them that what they're experiencing isn't real. In cases like that, all you can do is, keep an open mind, be clear about the fact that you don't agree with what they're thinking, but they agree that what they're thinking is upsetting them and bothering them. So in the context of a strong therapeutic relationship, you can sometimes get them to build enough trust in you that they'd be willing to try even a small amount of medication. But it can be a long process.
Well, yeah, I'll tell you something. Nothing in corrections is easy. I always tell people that, you have to work through a lot. Sometimes it's sad because the public doesn't know the honest work that goes on behind the wall. And that kind of brings me to the next subject here kind of brings me to the new topic of basically there's always been that push to get rid of solitary confinement, which I think is the primitive term. It's not solitary confinement. It's more of restrictive housing, AGSA, because they are getting their needs met. Mental health is there aggressively with what needs to be done. But having said that, there are still some inmates that maybe just that environment is not a good fit. How do we know that the inmate is not stable enough to remain in those isolated areas?
Well, I agree with you on the use of the term solitary confinement, first of all. Whenever I hear someone use that term, it tells me immediately that they have no experience actually working in the system, and that completely undermines their credibility. So I think we really need to stop using that term. With regard to putting people in restrictive housing, that should never be a first resort. So I agree with policies that would require people facing segregated housing to have either initial evaluation by a mental health professional or an evaluation soon after placement. I don't necessarily agree that mental health professionals should be offering recommendations to disciplinary boards. I don't think that's necessarily the role of a mental health professional. There's going to be disagreement among our correctional psychiatry community about that. But I would tend to prefer to have our role be maintained as strictly therapeutic, not potentially punitive.
So let me ask you a question, but you also agree that, would you agree that mental health professionals should be involved in when we do status evaluations to make sure the inmate is ready for that next level of status?
Yes, that's part of the disciplinary process of treatment. So when you have someone on a segregated housing status, making sure they have regular contact with mental health professionals, make sure they have the ability to request and have access to not just mental health, but also medical services. And then also you take their wishes into account. That's the biggest bugaboo I have with people who would completely get rid of restricted housing, because there are some patients who legitimately want to be there and they prefer to be there and they like it. And, I think in any other setting, no one would question a human being's desire to have privacy. But in the prison setting, for some reason, that's always looked at with suspicion.
Well, that's because they base it on extremes where the practices weren't what they were supposed to be, and that gets generalized, and then people start believing that that extreme is the practice, and then it takes us a while to tell people, no, that was an extreme. What the practice is literally the inmate is removed for GP for safety reasons, also for the population to remain safe, and also the inmates receiving programming, mental health needs are met, the inmate's not forgotten. And it's sad because, as I said, when the people are looking to change things, they don't realize that what they're changing may not be from the picture that they think it is. And now it makes matters worse.
Right, that's exactly right. I mean, the classic example I can think of that is at my prison clinic one day, I was evaluating a patient, and he mentioned that he was itching. And I thought, oh, that's interesting. Show me what's going on. It turns out he had an active case of chickenpox. Now, he wasn't physically sick enough to be in a medical infirmary, but he obviously couldn't be in a general population during the time when he was infectious. And the infectious period for chickenpox is 21 days. So by their reasoning, if I had put this person, which I did, he ended up getting put into medical isolation for 3 weeks. But by the human rights document, that would be cruel and unusual punishment, what we just did.
See, but again, that's the thing. That's always been the conflict in corrections, is that we have to be concerned about the many, and when people push on the outside, they're only concerned about the one. And there's the conflict, because someone that poses a threat to the environment, again, is not forgotten, but they do get removed so we can still focus on the many. And that's always the key. But I think people think that once the person gets removed, that they're forgotten and that they're in the dark and everything else that's extreme. And that's not the universal practice. And again, I can't speak on a whole, unfortunately, because I have never walked in every facility. But I can know from my perspective, what I've seen, when an inmate is removed from population, they're removed for a specific reason, but they're not forgotten. They're attended to more aggressively with programming than they were prior. So, and again, we're down to our last couple of minutes. I want to go over your book. I do agree it was a great read, because if I was an officer, it could definitely give me some knowledge in regards to some of the mental health sicknesses that people face. What do you think is the dominant mental health sickness that people are facing inside our prison, inside corrections, inmates?
By easy choice, the dominant problem facing all of my prisoners are substance use disorders. We focus a lot about the problem of mental illness and violence, but the largest factor related to any violence risk is an active substance use disorder. Alcohol abuse, drug abuse. Now we even have synthetic cannabinoids in our system. And if you could address that more aggressively, then I think it would make the entire system better and decrease risk of violence in the community.
Right, and these are concerns that you have to address at its roots, correct? I mean, you can't just go after the behavior. You have to go at what's causing the behavior, correct?
Right. It's a multidisciplinary process. So there are environmental factors and life choice factors and social support factors that all go into maintaining sobriety. So just like with mental health disorders, you have to address it as a whole.
Okay, so would you like to say anything to my audience in closing, Doc?
I'd like to say thank you all for working in the correctional system, and thank you for coming back to work every day.
Wow, thank you. Thank you for such a wonderful book, Committed, guys. You can get it on Amazon. Where else can you buy the book at?
Gosh, that is the main. You could also buy it in bulk from our publisher, Johns Hopkins University Press. You can Google the website.
All right, and again, I enjoyed the book. It was a great read, very educational, and I thought it was even, it was very informative because it relates to someone who worked in the field. Like you worked in the field, you know what it's about, so I was able to kind of draw from your experience and use that to get a better understanding of the book and also be able to apply that to what I do, because I sit on a lot of force med hearings myself. So, it's good to know that, there's a book out there that we can look at that can give us some information on the work that we do. So thank you again for a wonderful book.
Thank you so much.
All right, guys, so real quick, I want to do this show because, as you can see, and I get a lot of messages about the increase of those with special mental health concerns that come into the correctional facility. So I got a chance to read her book. The book is called Committed. The book deals with individual case studies or individual stories, but obviously it relates to what we do, because the sicknesses that the people face on the streets are no different than the sicknesses that are coming through our correctional facilities. And the good thing about this book is the book explains about involuntarily psychiatric commitment. That's the key, because that's what we're going through in our correctional setting. Sure, we have some that know they have issues and they want to do something to attend to those issues, but then we have some that just don't know, and now we have to step up. And the reason why we have to step up is for the overall safety and security of not just the individual, but the facility itself, and that's key. And that's why I thought it was good to have Dr. Hanson on the show so she can discuss her book a little bit, but also because she has a correctional background, she has a jail background, so I wanted to kind of see how both worlds blend. And I think that she was a perfect guest to have on, and the guest came from me through a recommendation through Corrections 1, so I want to thank Corrections 1 for getting me such a wonderful guest. So again, just another topic. The concern is great for us when it comes to those with special mental health concerns, because our population has increased in that regard, and I think it's great for people to know that we're stepping up as staff and handling those challenges, and that when they're behind the wall, we're doing the best we can to meet the needs that they have to have. And again, I would like to thank our correctional staff for stepping up, because like any challenge that comes your way, you're ready for it. As always, guys, subscribe to the YouTube channel. The show is Tier Talk. Love you guys. Stay safe. The cage is closed.